This is case CCTA number 32. This is a 48-year-old man who is an active smoker who has a presentation of atypical chest pain. He has a strong family history of premature coronary artery disease. It's a very complicated case with very interesting plaque characteristics. Up here there are 4 phases for review. Those can be changed by doing either the next or the previous button on the Cine control. Each of these phases is very important. This case also emphasizes, very importantly, the value of having multiple phases for review of a particular case. Let's start with the left main coronary artery. We have this in the center of the crosshairs. There clearly is no evidence for obstructive disease. Let's just change the phase a little bit just to be sure that we have no issues here. This appears to be clearly without obstructive disease. However, as we rotate around the left main, you can see that at the distal left main area and the proximal LAD region, there is an area, a layer of non-calcified plaque. This is non-obstructive, but this is a very important place. This is what we call the Fertile Crescent, which is the birthplace of atherosclerosis. It's a very common site to see some disease, even though it's uncommonly obstructive. Changing the phase, you can see that there are clear differences in what your perception of the amount of non-calcified plaque, but it's clearly non-obstructive. Let's proceed down the left anterior descending artery. You can see as we get into the proximal segment, there is some eccentric plaque here. This is calcified, but also has a layer of non-calcified plaque. This is a mixed lesion, clearly not obstructive. Moving on down lower, let's further examine this. There is also some more plaque coming in the mid-LAD. You can rotate around here. Now there is clearly an area here that we have to investigate just a little bit better, and that involves the mid area here. This looks like what I would say is probably ulcerated plaque. Let's change to another phase here. It's important that as you look at the phases, for instance, if you look back at this proximal lesion, you can see how the characteristics of the area change. It's important when you're looking at this to come up with the phase that has the least motion artifacts. If there's some calcification present, you should note that the calcification looks more like river rock. It's relatively smooth. If it looks like gravel, it is probably a motion contributing issue there with respect to that. But there is non-obstructive plaque in the mid-LAD. As we go down further, there's some mild luminal abnormalities, but nothing really significant. There is a registration artifact right about here. And you'll notice as you change through the phases, you can see this registration artifact become less evident. This is a very common situation. You really don't have to worry too much about it. And then you can see that the apical LAD appears to be relatively normal. Now let's go back just for a second here to look at some other areas, because right between the proximal and mid-LAD, there is an area here of what appears to be some other plaque. This is a sort of a first diagonal branch. It's hard to call exactly what this is, and you can see there is a borderline lesion in that area. Difficult to determine whether or not that is obstructive. So there's a borderline lesion. It's a very small vessel, as you can see. As to whether or not this is actually causing the patient's angina, that's a bit difficult. Let's look at the circumflex vessel. Follow this vessel around. There is some very mild plaque noted in the proximal segment. Really nothing of any major issues here. There is, again, some mild plaque, and the obtuse marginal here is a very normal looking vessel. Let's look at the right coronary as well. Let's switch to the foot view. Bring this down and concentrate on the RCA. As you can see in the proximal segment, there is some eccentric plaque here. This is difficult to characterize. Let's see if another phase will be helpful. This is possibly an ulcerated area with some non-calcified plaque, but clearly non-obstructive. As we proceed down into the mid segment, you can also see some eccentric plaque. This also may be ulcerated because the density of this extramural area probably is consistent with what we see for the individual lumen. Changing the phase again, you want to be sure to get a phase that has the least motion. This one appears to be the best. We don't have the splaying out of the vessel and the plaque. Let's get down to the distal segment. Here you can see there is some non-calcified plaque. Let's again change another phase. Very important. Yes, there is clearly some non-calcified plaque, but non-obstructive plaque probably in the posterior lateral. So this 48-year-old man has really quite serious in terms of plaque disease. He has possibly borderline, possibly obstructive lesion in the small D1, but otherwise there is no major obstructive lesions. Decisions as to what to do with this patient are sometimes difficult. He clearly needs a very advanced, aggressive medical therapy. He must stop smoking. As to whether or not we need to evaluate that D1 lesion, a stress test may be appropriate in this case to absolutely rule out any issues, but many clinicians would just say that's a small vessel and probably medical therapy would be appropriate at the present time.